Hi, my name is Carly Ornstein, and I'm the National Director of Lung Cancer Education here at the American Lung Association. And I'm so pleased to welcome you to our event today, addressing lung cancer disparities in no patient left behind, Black men and lung cancer. Thank you so much for joining. I am pleased to be joined by some wonderful Lung Association colleagues, as well as two great experts, Dr. Tom Cooke and Dr. Khadijah Mitchell. So before we jump into our wonderful panel discussion, I just wanted to let you know that you can type questions that you have in the chat box on your screen, and we'll get to as many of them as possible at the end. So right now, I'm going to hand it over to our National President and CEO, Harold Wimmer, for some opening remarks. Thanks.
Thank you, Carly. And hello, everyone, and thank you for joining us for the American Lung Association's webinar, No Patient Left Behind, Black Men and Lung Cancer. As the nation's longest standing public health organization, the American Lung Association has an extensive history of health promotion and advocacy work to reduce health disparities, both raising awareness of disparities and taking action to address them. In our work to improve the lung health of Americans, we want to reach all Americans, but especially those most vulnerable. As you know, today's webinar will focus on the stark disparity in lung cancer faced by Black men in our country. Our expert panelists will discuss the systemic issues contributing to this disparity and ways we can tackle this immense public health challenge. This webinar is a part of a series of events and resources we are highlighting in honor of Black History Month. The month of February is a time to celebrate the significant contributions Black Americans have made throughout history and engage in a meaningful conversation about how to continue down the path toward a more equitable society. In collaboration with our National Diversity, Equity, and Inclusion Council, in addition to this webinar, we have several special features focused on the Black community on our website that we encourage you to explore at lung.org. Now I'd like to turn it over to Deb Brown, our Chief Mission Officer, to talk about the Lung Association's strategic lung cancer imperatives. Deb?
Thank you, Harold. Well, lung cancer is a large part of the work that we do within the American Lung Association's mission. And our association has programs at the national and local level to increase screening, reduce tobacco use, encourage individuals to live, work, and play in smoke-free environments, test for radon, and to ensure a safe working environment, all of which are very important components to assist our commitment to defeat lung cancer. We are also committed to funding our own robust lung cancer research program, as well as advocating for increased funding from the National Institutes of Health. It is important to acknowledge that due to advances in treatment, patients are living longer with lung cancer. And all patients living with lung cancer deserve a high quality of life. The Lung Association is committed to raising awareness of the disease through our Lung Force initiative, which helps bring people from all over the country together, virtually right now, but hopefully soon in person, to be part of the movement to defeat lung cancer. This provides much needed camaraderie, unity, and support within the community. We are also committed to reducing the stigma associated with lung cancer and messaging in a way that unites the community. As I mentioned, connection is huge for those facing lung cancer, and we offer numerous support groups to help those facing lung disease. I encourage you to visit lung.org/lung cancer to learn more. Health equity has been a critical piece of our work for the past 115 years. It is the foundation of our education programs, our advocacy efforts, and our research. All of the work to help reduce the impact of lung diseases, including lung cancer. The association acknowledges the disparities that exist in lung cancer, and we are committed to our role in helping to eliminate them, which is why I'm so excited for our program today. With that, I'd like to turn the webinar over to Dr. Felicia Fuller, who is our Director of Health Programs for Illinois and Wisconsin, and also a member of our Diversity, Equity, and Inclusion Council. Felicia?
Thanks, Deb. Before we hear from our panelists, I want to set the stage with some informational but startling facts. As you can see from this slide, Black men have the highest rates of lung cancer in the United States. They are more likely to die from lung cancer than their white counterparts, and they are less likely to be diagnosed early, receive surgery, which can be curative, which means life-saving, or receive any treatment at all compared to their white counterparts. In today's discussion, we're going to find out why these disparities exist and the role each of us play in reducing disparities so no Black lung cancer patient is left behind. So now I want to turn it over to my colleague, Carly Ornstein, who will moderate this discussion. Carly?
Thanks, Felicia. As I mentioned, I'm so pleased to be joined by Dr. David Tom Cooke and Dr. Khadijah Mitchell. I encourage you to read more about these amazing individuals on our website. But briefly, Dr. Cooke is an esteemed thoracic surgeon from California, and Dr. Mitchell is a brilliant biologist living in Pennsylvania. And they all provide a unique perspective on the topic of lung cancer disparities in Black men, and I can't wait to jump in. So our first question is going to be for Dr. Cooke. So Dr. Cooke, why are Black men diagnosed with lung cancer at higher rates than white men?
Well, thank you very much, Carly, Harold, and the rest of the American Lung Association team. It's my pleasure to be with you all today and share the stage, the virtual stage with Dr. Mitchell. It's a very good question. You know, why are Black men diagnosed with lung cancer at higher rates than white men? And it's a kind of a question we have to tease apart. One, Black men have a higher incidence of lung cancer than white men, their white counterparts. So there's good news is that incidence of diagnosis has been falling in the last decades. And lung cancer incidence in all Americans have been falling in the last decades. And that's the reason for that is multifactorial, and we'll get into that for the rest of this webinar. But there are still disparities in that downward slope. So Black men are diagnosed with lung cancer at a higher rate than white men, even though the diagnosis rate has been falling in the last several decades. Now, why is that? So about 80% of lung cancer is a result of tobacco exposure, combustible tobacco exposure, specifically smoking. And we do know that over the last decades, again, although the prevalence of smoking in all communities in the United States have been falling over the last decades, the prevalence of smoking in Black males has been higher than white male counterparts over the last decades. The reason for that is multifactorial as well. Part of it is related to targeted campaigns for the tobacco industry within the Black community, the prevalence of menthol and specific flavored tobacco products that have been marketed specifically to the Black community as well. There are other factors that we don't know quite well, but we may suspect, but we haven't yet teased out. One is the influence of air quality on lung cancer. We do know from the World Health Organization that air pollution is a risk factor for developing lung cancer. And we do know from, especially in nations such as China, where there are cities with extremely high levels of air pollution, the lung cancer rates in those sites are very high. We do also know that within this country, many African American communities and communities of color live in areas with high levels of air pollution. And so that may play a role in some of the numbers that we're seeing. We'll talk a little bit about lung cancer screening, and it's interesting, the question says, why are Black men diagnosed with lung cancer at higher rates than white men? That also makes the assumption that diagnosis of lung cancer is effective in Black males. And we do know that Black males benefit from lung cancer screening less than other demographic groups, and I'm sure we'll talk a little bit more about that later.
Thanks so much. Okay, our next question is for Dr. Mitchell. Is there any evidence Black men are more susceptible to lung cancer from a biological perspective?
Oh, so thank you for that question, and I'd like to echo some of the things that Dr. Cooke brought up. So my training, I'm a human geneticist, and I think about lung cancer health disparities from that perspective in that slice of biology. And in particular, I look at precision medicine in Black men. And so precision medicine thinks about prevention and diagnosis and treatment, but taking into account the genetic background, the environment, which could include air quality, and lifestyle. And from a genetic perspective, all humans are about 99.9% similar. And that remaining 0.1% difference, that actually can provide clues to what's influencing lung cancer risk. So my research has actually found that, of course, there's shared biology between Black and white men, but some Black men actually have significant differences. So, for example, we've seen with increasing West African ancestry that they are more likely to develop lung cancer when compared to their white counterparts. And interestingly, there are particular genes found on your chromosome number 5 that have been linked to higher testosterone levels, as well as potential differences in drug response. And so we're currently teasing apart why that would be. What is the influence of this genetic ancestry in the lung cancer biology in Black men? And something else I think is very interesting is thinking about how you metabolize nicotine. So this is another important predictor of lung cancer risk. And there have been studies that have shown Black men have different versions of these genes that metabolize nicotine when they do smoke, like Dr. Cooke mentioned. And they can have higher levels of nicotine metabolites and carcinogens per cigarette smoked when compared with the same level exposure in white men. And so we're also currently exploring the activity of those genes in these two populations.
Thanks, that's fascinating. Okay, the next question is for Dr. Cooke. This is maybe a bit of a loaded question and we'll have to break it down a little bit, but why aren't Black men being screened for lung cancer as much as white men?
Yeah, so one, the big picture is that we have a national failing when it comes to lung cancer screening in the United States. In the American Lung Association State of Lung Cancer report, we do know that roughly about of all the individuals who are eligible for lung cancer screening in the United States, only about 5% actually get screened. Now, that's a little bit higher than the last estimate, which was around 4%, but 5% is pretty woeful. And then when you compare it to other screening modalities, such as mammography, about 70% of eligible women in this country who are eligible for mammography who get screened. And then you compare that to about 5% of all men and women in the United States who are eligible for lung cancer screening get screened. So we're doing very poorly in regards to screening. But what about Black and other communities of color? Less Black men get screened for lung cancer. And it's unclear why that is. We do know when we look at why our lung cancer screening rate is so low, when patients who are eligible for screening are surveyed and asked, why haven't you been screened? The majority say, well, because my physician or my primary care provider has not recommended it to me. So we do need better ways for our primary care providers to embrace lung cancer screening and recommend it to our patients. One way to do that is to empower patients in their own care, and that's through education. So if educating individuals to know that they may benefit from lung cancer screening based on their age, tobacco exposure, and time of quitting, and then encourage them to ask their primary care provider if they are eligible for lung cancer screening.
Thanks. And before we hop to Dr. Mitchell for the next question, can you talk a little bit about how the lung cancer screening guidelines might be changing to incorporate more communities of color into the screening process?
Yes. The current guidelines for lung cancer screening with low-dose CT scan is age 55 to 80. You smoked 30, what's called 30 pack years. So pack years is you take the number of packs per day that you smoke times the number of years that you smoked. So if you smoked 1 pack per day for 30 years, that's 30 pack years. Or if you smoke 2 packs a day for 15 years, that's 30 pack years, and so on. And if you're a former smoker, then you've quit within 15 years. So if you fit those criteria, you're considered a person of high risk for developing lung cancer and should benefit from lung cancer screening. However, we have data that shows that Black men may benefit from, or Black individuals, Black patients may benefit from lung cancer screening at an earlier age, as well as a lower tobacco dose exposure. So the U.S. Preventive Services Task Force has changed their recommendations from lowering the age of eligibility from 55 to 50 and lowering the pack year eligibility from 30 to 20. There's also data that suggests that women may have a higher incidence of lung cancer at lower tobacco exposures. So the thinking is that lowering the age and lowering the tobacco exposure criteria for eligibility would then incorporate a lot more high-risk Black and African American individuals, as well as incorporate a lot more women into the high-risk category, and then, of course, save more lives.
Thanks. Yes, and the Lung Association will be doing a lot of communication about the guidelines. So this question's for Dr. Mitchell. Dr. Mitchell, since I know you have a lot of experience working in community health, can you discuss some ways to address barriers Black men might face to accessing lung cancer screening?
Sure. So I spent a lot of time working with communities of color, and in particular, to echo what Dr. Cooke said, health education is very important. So health education interventions in the communities must address common myths and misconceptions. And so there's a lot of work being done around screening and Black men's use of particular cancer screenings. So we can think about in particular in lung cancer is the myth that only smokers can get lung cancer. So Black men wouldn't need to be screened. And also thinking about, so it's important to understand that there are various subtypes of lung cancer. And in fact, even the lung cancers that come from individuals who never smoked have their own unique tumor biology. So that's a common misconception. And also that Black men may not be at high risk unless they had a family member that passed away due to this disease. And so we also encourage health-seeking behaviors. So we know that as a population, Black men typically don't share as many fears about their health findings with their families and friends. So creating environments and support structures with families, that also will help with encouraging those behaviors. And finally, empowering the patient with shared decision-making with providers they trust, like Dr. Cooke. So most likely that if a patient trusts their provider, that they're more likely to actually follow through with their lung cancer screening once it's recommended.
Great, and before we go back over to Dr. Cooke, just a follow-up question. Your thoughts on what about patients that don't have a primary care provider? How do we address that barrier and still get these patients screened?
Right. So in that regard, we find that community support has been very helpful. There are models, for example, with neighbors and friends, and using community accessing, for instance, public community clinics and things of this nature. There are easily accessible, more available the hours that an individual would work or things like that, even if they don't have a primary care physician. Federally qualified health centers has actually been very key with some of these initiatives.
Great, thanks. Okay, back over to Dr. Cooke for the next two questions. Dr. Cooke, why do Black men and women have poorer lung cancer outcomes than their white counterparts?
Yeah, so we could sort of walk, Dr. Mitchell kind of alluded to a lot of these things, including access to care. So we do know that Black men and Black men and women, but especially Black men, are diagnosed at a higher stage of lung cancer compared to their white counterparts. And we do know that the lower stage that you're diagnosed and treated, the best chance you have for cure. So if there are 4 stages of cancer: stage 1, 2, 3, and 4. And if you're treated with evidence-based medicine at stage 1, you can have up to an 80% chance of cure, and that means surviving through 5 years without the cancer coming back. We do know that Black males, especially, undergo lung cancer screening less than their white counterparts. So if you look at stage of lung cancer diagnosis in this country, the majority of individuals who are diagnosed with lung cancer are diagnosed at stage 3 or 4. So the highest stages and the lowest chance for cure. So 75% are diagnosed at stage 3 or 4. However, for the lung cancer screening population with low-dose CT scan, 75% of lung cancers identified with lung cancer screening are diagnosed at stage 1 or 2. So there's a complete stage shift. So those who undergo lung cancer screening when they're diagnosed, 75% are diagnosed at stage 1 or 2, the highest chance for cure, while in the general population, 75% are diagnosed at stage 3 or 4, the most difficult chance for cure. So if Black men are undergoing lung cancer screening at less rates than other demographics, then they would benefit less from that stage shift and survival advantage. And on a third point, we do know that for Black males who are diagnosed at stage 1 or stage 2, or even stage 3, they're less likely to undergo surgical therapy for their lung cancer. And evidence-based medicine shows that surgery is the standard of care treatment for stage 1 or stage 2. And surgery should be part of the what's called multimodality treatment paradigm for stage 3 and even some stage 4 cancers. And then finally, we look at clinical trials. When we see the decrease in mortality from lung cancer in our nation over the last several decades, that's a direct response for tobacco cessation interventions, tobacco control advocacy, lung cancer screening, standard of care surgical therapy, including advanced surgical therapy such as minimally invasive and robotic surgery, and also enrollment into therapeutic clinical trials that look at the novel application of precision medicine. And we do know that our Black and African American and other underserved communities are less likely to enroll in therapeutic clinical trials than other demographics. And when you add all those things together, that and other things I haven't been able to talk about, but Dr. Mitchell alluded to, those factors can lead to poor outcomes.
Great. Before we go to the next question, I just wanted to pause on surgery a second. Can you discuss maybe some of the common myths or misconceptions that may be in Black communities about surgery? Sure.
So there are some sort of basic myths, and then we'll get to sort of a bigger picture. You know, one prevalent myth is that when you operate on someone, you expose the tumor to air, and that could cause metastases and spread. And that is not accurate. And the reason why that's not accurate is because probably in the sort of the olden days when we operate on patients, we didn't have the type of imaging technology that we do now, such as something called a PET scan and other imaging modality. And we may have been operating on individuals who may have already been stage 4 and we didn't realize it. Those patients then went on to advance their tumors, and it made it seem like surgery exacerbated that. So that's one prevalent myth. I think the bigger picture is as follows, and that's sort of the mistrust of Black and African American communities and other underserved communities, communities of color, of the healthcare system. And that mistrust is warranted based on historical structural racism in healthcare and current disparities that we see, that much of which can be attributed to legacies of structural racism. Surgery is invasive, but we, just like in medical oncology, radiation oncology, and other factors, we've had multiple advances in technology to make surgery safer, more comfortable, less pain, and faster return to work. The onus is on us as care providers to earn that trust of those communities and really talk about different therapeutic interventions, including surgery, and be transparent about all the different innovations and advancements that we have done to make it safer for patients, and therefore part of the evidence-based armamentarium for fighting and beating lung cancer.
Thanks for going into that. For the next question, can you talk about, I'd love to hear your perspective on ways to address some of these disparities in treatment, especially access to surgery or reluctance to receive treatment.
Yeah, so I often say one of the best ways to mitigate health disparities is to practice evidence-based medicine. So that means not to make assumptions about a patient of what they may want or may not want. Ask them, what do they want, right? What outcomes are most important to them? And then sitting down and having discussion with that individual about what evidence-based medicine is and what concerns that they may have, right? And many of their concerns may be easily explained and allow that individual to want to pursue evidence-based medicine. So that's the main thing. I spend a lot of time with my patients answering questions, going into details, and having empathy and compassion and understanding their point of view. And I'm able to do this and still in my clinic on time, so my nursing team and my medical assistants can still go home on time and take care of their families. So, you know, we can walk and chew gum at the same time. We can really have a relationship with our patients, listen to their fears and concerns, earn that trust, and then practice evidence-based medicine. So I would implore on all my colleagues out there who are also primary care providers or surgeons and et cetera, is to practice evidence-based medicine. When someone has stage 1 and stage 2, so early to locally advanced lung cancer, talk about surgery, offer a clinical trial, refer patients to really good, high quality evidence online. That includes the cancer.gov website, that includes websites for comprehensive cancer centers, and that includes websites such as offered by the American Lung Association, where individuals can get really high quality information.
Thanks. Okay, next back to Dr. Mitchell. Dr. Mitchell, how does tumor biology impact how we view disparities in cancer care?
So that's a great question, Carly. When we think about differences in tumor biology, we think of many different, I guess, phases of a tumor's progression. And you can think about early stages, late stages. You can think about DNA, RNA, proteins, and different biomarkers that you can use to address the tumor biological problem. And I think one thing that has been understudied is appreciating the background of the patient. So we often think about a Black man as a self-reported race in his construct, but in fact he could have a very unique biology depending on if he had more African ancestry, European ancestry, or even Native American ancestry. And we know that these different different ancestries confer different risk as well as more aggressive disease. We've seen this in other cancers with known disparities, such as prostate cancer. And so what we're trying to now do in lung cancer is understand how those same factors could play out with care, whether we're talking about preventing lung cancer and thinking about risk prediction, if we're talking about diagnosis or prognostic biomarkers, or even thinking of treatment. And in particular, what would support what Dr. Cooke just talked about surgery is thinking about the right dose of the right medicine at the right time according to an individual's biology. And so the type of projects that I've worked on and the findings that we've seen is that Black men could have very unique mutation profiles, and there are certain targeted therapies that would make their treatment outcome more favorable if we consider their genetic background and other different tumor biological markers. I think historically, because of underrepresentation of Black men in clinical trials and research, a lot of what we've known about the biology of tumors have come from white men. And in fact, we see that there are different variations in populations that may not line up one-to-one. And so it's very important that our comparison and reference groups reflects the biology of the actual patient.
Yeah, that's a really good point. Something that I'd like you to talk about, if you don't mind, is to bring it back to lung cancer screening. Is are you looking at any markers that might be used for lung cancer screening, or a way to tell if a patient would be more susceptible to lung cancer? You mentioned a little bit, but if you could go into a little bit more.
Yeah, so that's interesting. That's a little, you have to tease that apart. So it would not replace screening by any means, but it could be used in conjunction to stratify patients better. So we have looked at circulating markers and serum markers, and perhaps that would the hope would be that was used to help with risk prediction.
Got it, thanks. Okay, so back to Dr. Cooke. I think this has been a really good background, but I also think it's really helpful for everyone to kind of understand their role in reducing disparities, because we all have a part to play. So I'm going to take it one bullet point at a time, but I'd like to know, Dr. Cooke, what you think the medical community's role is in reducing disparities.
Yeah, before I tackle that, I just want to follow up on one thing that Dr. Mitchell brought up in regards to the genetics of the Black African American community and maybe the role of lung cancer. Although race, as we know, is largely a social construct, there are and may be specific genetic elements in the Black community that may be apropos to fighting lung cancer. And that really highlights the need for Black and African Americans to participate in therapeutic clinical trials and to understand those differences. One positive outcome from this terrible COVID-19 pandemic is the vaccines that emerged. And the federal government really pushed on the private sector to include communities of color into their vaccine enrollment. And one company had an issue of the business as usual when they released their phase 1 data. To the federal government's credit, they saw that, listened to complaints, and another company learned from that and really pushed to have communities of color in their clinical trial, to the point where their clinical trial had 25% Hispanics and 10% Black African Americans, and that's pretty much unheard of for clinical trials. So we do need more Black African Americans to be participating in clinical trials. And so I think that sort of segues in what can the medical community do? So again, we need to enroll communities of color into clinical trials. And that means that we have to earn the trust of communities of color in order to do that. There's a long history of negative experimentation on Blacks and African Americans, whether that's the Tuskegee syphilis studies from the 1940s to the 70s where Black men who had syphilis were not told they had syphilis and were not given penicillin for treatment, so the natural progression of syphilis could be observed. That study went on for 30 years, and the CDC was aware, as well as the FDA and AMA, and even the National Medical Association before the study was shut down. There are other examples throughout history. And so that is in the cultural DNA in some of our communities of that mistrust. So we have to earn that level of trust. How do we do that? One is diversification of our medical workforce. So that means increasing the pipeline of Black African American women, Latinos, and other communities of color as medical students, nursing students, nursing workforce, physician workforce, and so we can have that sort of level of cultural comfort within the communities. But we can't wait for that to happen. We have to educate our care providers to be culturally competent and have cultural dexterity, empathy, and compassion for communities of color. And like I said before, one of the best ways to mitigate health disparities is to practice evidence-based medicine. So stop making assumptions about patients. For instance, as Dr. Mitchell pointed out, some genetic factors may suggest that Black African Americans may have more aggressive disease presentations. We do know that in breast cancer, and I think we're getting a little bit more information in lung cancer. So if you are a healthcare provider and you read this study somewhere that Black African Americans may have more aggressive disease, and someone comes to you with stage 2 lung cancer, don't be nihilistic and send that patient for non-surgical treatment and just definitive chemoradiotherapy, which is not the standard of care treatment, because you're saying, oh, well, they have aggressive disease. They'll probably have aggressive disease. No, practice evidence-based medicine and send them to a specialist who understands surgery and have a sit down and an open, transparent conversation about the role for surgery in their relatively early stage disease. So that's one example of what the medical community can do.
Yes, thank you for that. And then this is another big question, but what's the role of the government in helping to reduce disparities?
Yeah, so when I see that word government, I also see the word advocacy, right? Because the government is the government of the people, and really is the people that really tell the government what to do. And again, I'll harken back to that downward slope of incidence and mortality of lung cancer in the United States for all groups, even though there is a disparity of that downward slope, but it's a slope for all groups. So one is you look at the number of states, for example, you can look at the number of states that now have age 21 requirements for tobacco products. And for many states, those tobacco products include not just combustible tobacco, such as cigarettes and cigars, but also quote unquote vaping and other non-combustible tobacco products that are also harmful to our lungs. We look at local bans on menthol and flavored tobacco products. We look at tobacco taxes that have been raised throughout the nation. And all those interventions have caused a market drop in the adoption of smoking within our communities, and that we feel is correlating to the drop in incidence of lung cancer, as well as many of these interventions have taken over decades. That doesn't mean that we take the pedal off the metal, because we see a higher rate of adoption in our young people of vaping and other similar tobacco products or similar nicotine based products. So we still have to be active in that. we see Medicaid expansion throughout our states. Medicaid expansion that occurred immediately after the Affordable Care Act, but now we see state legislatures that didn't expand initially, and referendums voting to expand Medicaid in states that didn't initially expand Medicaid. And data shows that in states that have Medicaid expansion, we have higher survival rates for lung cancer, as well as higher surgical rates for early stage disease. And then for those individuals who are less than 65, we have the ability in many states to screen with zero to minimal cost to the patient. We are still having advocacy efforts for many organizations, including the American Lung Association, that spend frequent time on the Capitol Hills, both in our states as well as the federal government, and our national legislature to advocate on the behalf of individuals who have lung cancer and are at high risk for developing lung cancer.
Thank you so much for that thorough answer. So Dr. Mitchell, back to you. Let's see what you have to say about the role public health leaders have in reducing disparities.
So I think that public health leaders actually can address disparities, particularly in Black men, in 3 ways. And a lot of what Dr. Cooke said parallels what I'm going to say. So definitely we need tailored interventions to promote prevention in Black men, and screening, so evidence-based strategies that actually would increase lung cancer screening in those men that are eligible. So one thing that we know works extremely well when it comes to screening intervention is partnering with trusted sources in the community. And so that could mean taking individuals from particular communities that Black men live in and training community health workers, right, to educate and make the community more aware of lung cancer screening. And one strategy that's been very effective with Black men has been barbershop initiatives. So we've seen this be very successful in regards to prostate cancer and COVID-19 actually testing as well as vaccinations. So we think this could expand and be a bright spot for lung cancer screening as well. And in particular, thinking about smoking. So yes, smoking has gone down over the decades, and particularly because African-American men in tobacco targeting and advertising will smoke menthol cigarettes more likely, I've seen wonderful effects on reducing disparities with targeted tobacco cessation programs for menthol cigarette smokers. And this is important because there are a lot of literature that says that nicotine and carcinogen exposure could be greater in menthol cigarette smoked. So having special tailored initiatives for that type of smoker has actually helped with reducing disparities. And I think the third thing I'd like to end with, particularly thinking about public health leaders, is radon control, because radon is the second leading cause of lung cancer. I know we talk a lot about smoking, but in fact, there are people who are exposed to radon, which is an odorless and colorless gas. And when you look at the cities and counties around the country that have the highest proportion of Black men, that actually coincides with area of high radon levels. And so if we could have initiatives that would target radon control, we also would be able to target some of this reduced disparity.
Thank you. Yeah, that makes total sense. And lastly, what do you think the role of the general public has in reducing disparities?
Well, I think, there's a common misconception you need a PhD or MD to make a big change. And I think that the general public should understand that, 2 key things could happen. First is to reduce stigma for smoking. And I think also to increase education and awareness of lung cancer in family and friends and people that you know. So this actually would just require a kitchen conversation.
Interesting. I was going to also say that when you brought up stigma, it's interesting. We've been talking a lot about tobacco, and tobacco certainly has a really big role in lung cancer, but there's also quite a few people who don't have a smoking history that have get lung cancer. So important to kind of also talk about the symptoms and recognize that there's multiple risk factors. Okay. So right now we are going to move into the question and answer portion. So please type your questions in the chat box. I'll give you a second. And I think Candace, my colleague Candace Alexander, who is also a member of the Diversity, Equity, and Inclusion Council, is going to help me with the questions. Candace, do we have any questions so far?
Yes, and I believe this one is directed to Dr. Cooke. Are the changes to screening recommendations that you mentioned for all or just Black persons?
So they are for all individuals. So the U.S. Preventive Services Task Force gives a recommendation on certain screening and preventive medicine interventions. They gave a grade B for those recommendations. According to the Affordable Care Act, anything that's given a grade B or higher is required by law to be considered an essential health benefit for private insurers. Now, that then becomes a recommendation to the Centers for Medicare and Medicaid Services, and then they individually decide whether to adopt those recommendations for their Medicare and Medicaid beneficiaries. But big picture, that is for all individuals, hoping to catch more Black and African Americans and women who would benefit from screening, but is a recommendation for all individuals.
Thank you.
Thanks so much. I actually, while we're waiting to see if we have any more questions, and I have a question for Dr. Mitchell. Dr. Mitchell, can you talk about if the changes that you're seeing or the genetic differences that you're seeing in Black populations, is that something that is kind of inherited from families? Is it familial, or is it just a change that's happening because of exposure to some kind of carcinogen?
So that's a great question. It's a little bit of both. So when I'm looking at changes that are required over time, so I can see sometimes that there are changes associated with exposures, whether this is environmental exposures, smoking or not, neighborhood factors. We can actually track the type of genetic change as something that was acquired over time. And there are some changes that you're born with, and you may or may not share some of that with a relative, but more so when we think of the type of genetic changes I'm looking at changes over a long period of time. So I'm looking at changes that may have occurred through generations and generations of families.
And on that point, you can stay on, Dr. Mitchell. Can you talk a little bit about epigenetics and epigenomics? This is fascinating to me. The idea that this chronic stress, like Black populations have experienced because of racism and slavery, does that impact our genes?
So that's another great question. In fact, my training, I trained with Steve Baylor at Johns Hopkins, was actually in epigenetics, and we have some projects in my lab looking at that. And so, in fact, epigenetics is a reversible change to some type of stressor or environmental exposure. And there are tons of studies that have shown, at least in mouse models, as well as in some patient samples, that there is reversible changes in regards to stress. And so the same is similar to we see in individuals who parents experience Holocaust, whether people who went through drought and stress. We see that individuals of African descent in this country have some markers at genes that are associated with the stress axis and response. And this can then be passed on to germ cells that would go on to future generations and children. So there are areas of active investigation of looking at epigenetic changes and the influence of chronic stress in this population.
Thanks. Candace, do we have any other questions in the chat box?
I currently see no others.
Okay, we can always come back at the end. Oh, I think I just saw another one pop in. I can read it since I'm looking at it right now.
Okay.
Patient navigation is critical to education, access, and clinical trial participation. How do you see that being promoted for this population? So I think that would be a good one for Dr. Cook to talk about the role of patient navigation.
Yeah, patient navigation is excellent utility. So, you know, we talked a lot about patient education and patient activation. So a patient is going to really trusted sources of information, reading or listening about the information and understanding their disease processes and their risk factors. And then activation is deciding to go to our healthcare communities to get care. But then once they get there, the healthcare system can be a very difficult system to navigate. And some of my sort of tech colleagues out here in California would even argue that the healthcare system is even not a system, right? Because a system implies that there is communication with different nodes of the overall system. And we do know from healthcare that oftentimes there's a lack of communication from one site to the other. How do you, when are your tests scheduled for? Are they scheduled in a convenient manner for you based on your personal life and lifestyle and job requirements? How easy is it to get to be enrolled into a clinical trial, and et cetera, et cetera, et cetera. So many institutions, including ours, for our thoracic surgery program, we have a individual named Valerie who's a patient navigator. So just to use our program as an example, about 30% of our patients in our thoracic surgery division here at UC Davis travel 50 miles or more to get their care with us. We care for a large rural population. And 15% of those individuals travel 100 miles or more. And so Valerie, our patient navigator, works with them on the phone and works with their care team at their own communities to sort of coordinate their care. Currently, about 40% of our outpatient interactions are done by telemedicine. And that has, again, another positive thing that comes out of this negative COVID-19 pandemic is the loosening of regulations on telemedicine and allowing us to provide that easy access. And we found that for our patients with geographic limitations, as well as transportation limitations, which affects communities of color, now they are more engaged with us. And we've actually been able to enroll more individuals in clinical trials that way. So patient navigation really is a must to help our communities achieve evidence-based care.
Thanks so much. Okay, Candace, I think we have a few more questions that popped in.
Yes, and one is, and this could go to either of our speakers, how can we in the white community go about respectfully addressing these topics one-on-one with the African American community?
Let's go and have Dr. Mitchell respond to that one.
So that's a great question. I think one thing is cultural humility. I think we talk a lot about cultural competency, but I think cultural humility is recognizing when you don't understand a particular aspect or feature or factor of a culture, but being willing to listen and learn. Right. And so I think that just approaching and having an open, honest conversation about the disparity, about the factors that contribute to the disparity, and also coming up with earnest solutions and having this cultural humility approach would be one way to start.
Thanks so much. Okay, Candace, you want to read us our last question before we go on to closing thoughts?
Yes. Is the use of nicotine replacement therapy a risk factor for lung cancer? And is the long-term nicotine replacement therapy, such as the gum patch or lozenge, risk factors for lung cancer?
We can have Dr. Cook answer this one.
So nicotine replacement therapy, as offered in a legitimate smoking cessation strategy or program, is not a risk factor for lung cancer. Now, some people might look at vaping as nicotine replacement therapy. And it really is no longer nicotine replacement therapy. Now it's more of a smoking gateway drug, really. Gums, patches as a part of a smoking cessation program is not a risk factor for lung cancer. In fact, it may reduce your risk for lung cancer by getting you off of tobacco. Vaping itself has really sort of lost that value as an intervention, and now it's more of a gateway to tobacco use.
Thanks for clarifying that. We'll stay on Dr. Cooke, and Dr. Cooke, are there any closing thoughts you'd like to share?
I really would like to thank the American Lung Association for taking the time for this really important discussion. And I'd like to thank Dr. Mitchell and to sort of piggyback on what Dr. Mitchell said about having discussions amongst all demographics and cultural humility. We really have to be comfortable with being uncomfortable, because we all want to believe that we live in a just society. And, you know, our United States society is excellent as you compare it to the rest of the world. But just because it might be excellent as we compare it to the rest of the world does not mean that we have market ground for improvement to make our society even more just. And that means having conversations that may make us feel uncomfortable. So we have to be comfortable with being uncomfortable. I really implore our audience to really seek out really good information. That could be with cancer.gov, with the National Cancer Institute, as well as lung.org. American Lung Association has really good information on lung cancer as well as air quality. And then with social media, I'd be cautious with social media, but we do have something called #LCSM or lung cancer social media on Twitter. And there's a lot of really good evidence-based curated conversation on Twitter using the #LCSM and lung cancer. Again, thank you very much, and I really appreciate being here today.
Thank you. Our pleasure. Let's go over to Dr. Mitchell for some closing thoughts.
Okay, so again, I would like to echo what Dr. Cooke said. Thank the American Lung Association for the invitation to talk today. And I think what I would like to leave everyone with is this is a multifactorial issue, right? And reducing lung cancer health disparities requires approaching this from all sides, and that includes wonderful clinical providers like Dr. Cooke. It includes scientists like me and all of my colleagues, but it also includes everyone who's on this line right now, includes the community, and I mean large C community, whether this is in your neighborhood, whether this is in your state, whether this is across our nation. And I think that everyone can do a part in thinking about increasing screening, decreasing tobacco, and increasing participation of minorities in clinical trials, and having compassion and empathy and thinking about those who are living with lung cancer. So increasing awareness and reducing stigma, increasing support, whether that's social support or community support, that will ultimately lead to promoting health equity and reducing this disparity. And I guess the last thing I'd like to leave with is that, you know, many hands make light work. And I think about that a lot, and we each can do our part to help this particular segment of our population. Thank you.
Thanks so much. I'd like to hand it over to Dr. Felicia Fuller from the Lung Association.
Yes. I guess I definitely want to thank our speakers. That was an overload of information for about a 50-minute conversation, so I'm definitely happy about that. A couple of things that stuck out to me as a public health official. Dr. Cooke mentioned that only 5% of people that are eligible for getting screened with lung cancer are getting screened. That means 95% of people are not. And then we see disparities within that. So I think for me, that's a take home. Dr. Mitchell discussed tailoring interventions to meet populations, specifically the Black men population where they are. Both of these are very critical in, and not just prevention, but early intervention like that was discussed today. Very quickly, I'd just like to thank my teammates, Candace Alexander and Carly Ornstein, in helping in putting this and helping us put this together. And definitely on behalf of the Diversity, Equity, and Inclusion Council, I thank everyone for joining us, taking some time out of their Friday, and hopefully taking some of these tidbits to help in their clinical, their advocacy, and their health education work around lung cancer. So Carly, I know you're going to talk about some volunteer opportunities for people.
Thank you so much, everyone. Before we go and you go on with your busy days, I wanted to tell you that we need you. We are doing an advocacy day, a virtual advocacy day, and we are looking for people who have experience with lung cancer, whether you're a survivor, a patient, or caregiver, one of your friends or loved ones has had the disease, specifically from these states, and we'll be able to do what Dr. Cooke was talking about, telling our elected officials that we need more research and funding. So please, if you are interested, you can email annette.iyer@lung.org. You could also just chat in this box and say that you're interested, and we'll follow up with you, but please spread the word. And real quick, next slide. We are also collecting stories about people who have stories accessing healthcare during the COVID-19 pandemic. If this is you, if you have something to share about how you accessed your healthcare during this pandemic, you can either chat us or email champions@lung.org. Thanks again, everyone. Really appreciate your time and this wonderful discussion, and I hope you have a great weekend. Thank you.
Thank you very much.
Thank you.